Welcome to today's webinar about the common question nurses hear about EoE featuring Stephanie Skirka. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. We're pleased to have Stephanie join us today. She is a program coordinator and clinical nurse at Children's Hospital Colorado in the Gastrointestinal Eosinophilic Diseases program. Over the last 25 plus years of nursing, she has received a lot of questions from patients and families. We are so glad she is here today to share some of her experiences and expertise in GI medicine and eosinophilic diseases. Welcome, Stephanie.
Thank you so much. So good morning and good afternoon to everyone. I first want to tell you a little bit about myself. I'm a native to Colorado, and I have dedicated my career in nursing to children, and what brought me to Children's Hospital Colorado. So the last 7 years have been dedicated to the eosinophilic diseases program at Children's Hospital Colorado. So I first want to say thank you to APFED for giving me this wonderful opportunity to speak with you today. It is absolutely an honor, as APFED has been such a great resource for our patients and families. I also want to thank all of the physicians, the medical team, the researchers, the management that I work with on a daily basis. They have given me the knowledge that I'm also going to share with you today. And then thirdly, I would like to thank my patients and families and all the patients and families out there, as you have truly enriched my life and I'm sure enriched others. It's really nice to have a glimpse of what you're going through. So the talk today is the common questions nurses hear. So I first want to say who we are at Children's Hospital Colorado in our eosinophilic diseases program. So our mission is to improve the quality of life for patients and families affected by eosinophilic disease. We have a large multidisciplinary evaluation that includes evaluations from a gastroenterologist, allergist, registered dietitians, feeding specialists, researchers, and psychologists. So we're going to review and answer most common questions nurses hear from patients and their families. So what are the common symptoms of EoE? How is EoE treated? Does EoE go away? Is EoE hereditary? How is EoE diagnosed? What happens if my child does not take their medications? How often does my child have to have an endoscopy? And is there any other way other than an endoscopy to monitor disease progression? So let's start first with the GI tract. So the esophagus is the tube through which food passes from the throat to the stomach. And this is where we're going to focus our discussion today, is on the esophagus. So what is EoE? Eosinophilic esophagitis, it's a chronic disease in which a type of white blood cell called the eosinophil builds up in the lining of the tube that connects your mouth to the stomach, and that's the esophagus. So those eosinophils should not be in the esophagus, and when they're there, they can cause inflammation and irritation. So depending on the part of the gastrointestinal tract affected, the diseases can be called a variety of different names. As I said, we're going to focus on eosinophilic esophagitis, but if the eosinophils are in the stomach, may be called eosinophilic gastritis, or if they're in the lower part in the colon, they can be eosinophilic colitis. So let's talk about the symptoms that EoE can cause. I'm breaking it up into younger children and then older children and adults. So in our younger children, ages to 2 to 6 years of age, we may see feeding difficulties, gagging, vomiting, refusal to eat. They may have some regurgitation, which is when food or liquid or stomach acid flows back up from the stomach into the esophagus and then the mouth. They may present with a food or foreign body impaction. So a piece of food may get stuck in the esophagus, or a pill may get stuck in the esophagus, or abdominal pain. Older children and adults, so 7 years and up, we may get dysphagia. So again, difficulty swallowing foods or getting foods down. They may present with a food impaction, again, where a piece of food or pill gets stuck in the esophagus. They may have chest pain, mainly upper chest pain. We may see regurgitation. And again, that's when food, liquid, or stomach acid flows back from the stomach into the esophagus and then the mouth. So, how is EoE diagnosed? So, there's some diagnostic criteria, and we combine clinical findings with microscopic findings, meaning findings on an endoscopy. So, some of the clinical findings that patients, as we had discussed before, may present with is difficulty swallowing, food refusal, and that in combination with if an endoscopy is recommended and done, that in the biopsies, we may see greater than 15 EOs or eosinophils in the upper, mid, or lower esophagus. So once it's diagnosed, how is EoE treated? Um, it could be done with a procedure, a dilation of the esophagus, and I'll talk about that a little bit more in detail further on in the slides. Medications, we could be treated with topical swallowed steroids, proton pump inhibitors, or biologics, or it can be treated with dietary therapy. There's elimination diets, allergy directed diet therapy, or elemental diet. So we always ask, like, what is the goal of EoE treatment? We always want to improve symptoms. We aim to maintain the growth and development of the child. We want to prevent complications, and we choose a treatment that will maintain quality of life. So, treatment is based, and when we say we give individualized care, it truly is individualized. So, we want to take into account the child's age, what part of life they're in right now, and what treatment would be the best for them at this time. So let me talk about the procedure. So what is an esophageal dilation? So esophageal dilation is used to stretch open a narrowed area. It can be called a stricture in the esophagus or another part of the gastrointestinal tract. Um, there are several different dilators. There might be a dilator called a bougie dilator, which would be used to treat a narrowing that's a greater segment of the esophagus or a larger portion of the esophagus. Or we may use a balloon dilator, and that would be if that narrowing is at a focal part in the esophagus. These are some radiology images. So on the left is a normal esophagus. And then as you can see on the right, it's an esophagus with the stricture or the narrowing. So that is what we're talking about when we say the narrowing of the esophagus or stricture. So, what are the potential complications of an esophageal dilation? The most common complication that we see post esophageal dilation is chest pain in about 14.7%. The endoscopist performing the endoscopy, along with the anesthesiologist, will go over other uncommon risks or complications prior to the procedure. So, can esophageal dilation be done too often? And I think this question comes up because I think people are afraid that if you dilate too often, maybe there's a buildup of scar tissue, but that's not necessarily true. So, esophageal dilation procedure cannot be done too often, and it's recommended based on the child or patient's treatment course and will be recommended based on the physician's recommendations. So, what are the medications used to treat EoE? We've got swallow topical steroids, proton pump inhibitors, and biologics. So, what are swallowed topical steroids? They're a medication that decreases inflammation in the swallowing tube or the esophagus. It's swallowed and coats the esophagus. And we oftentimes when we prescribe or we when we prescribe when the doctor prescribes the medication, we will make sure that the family is educated that they should not eat, drink, or rinse their mouth out for 30 minutes after taking. And that's to allow for that medication to really help with the inflammation in the esophagus. The effectiveness of swallowed topical steroids is 60 to 90%. So, most commonly used topical steroids are Flovent, or otherwise called fluticasone. And this is commonly prescribed as 2 puffs swallowed twice a day. And this is used without a spacer. We also can use Alvesco, often called ciclicinide, and it's also commonly prescribed as 2 puffs swallowed twice a day. And then swallowed budesonide or Pulmicort. And this comes not in an inhaler form, but it comes in a respule, and the little respule or vial holds 2 milliliters of the medication. And then that 2 milliliters of medication can be mixed with a nutritional supplement called Neocate Nutra. We can use Splenda to mix in with the liquid medication. We can use applesauce or a teaspoon of honey. I shared this slide just to let you know, it's got, dosing on age, but just wanted to let you know with topical steroids, we base the medication dosage on the patient's age, not weight. So what are the side effects of swallowed topical steroids? I just want to start with saying we don't see side effects very commonly. So it's uncommon that we see this, but oral thrush can happen. And that's when white patches on the inside of the cheek or tongue that does not brush off can happen or occur. We sometimes can see behavior changes. It's usually in our younger children, and it may present as irritability or anxiousness. We can also watch for adrenal insufficiency. And this is when the adrenal glands that produces cortisol, or what we would call our steroid, does not produce enough hormones. So the body, when we're giving the body steroids, our adrenal gland may say, gosh, the body has enough cortisol in it, so we do not have to make it anymore. So we want to make sure that that's not occurring. So we commonly follow up with some labs to check on that. What are proton pump inhibitors? Well, they reduce stomach and acid production. The common proton pump inhibitors that we use are omeprazole or Prilosec, lansoprazole or Prevacid, esomeprazole or Nexium. So previous guidelines would recommend that we would do a proton pump inhibitor trial to rule out if there is reflux as the cause of esophageal eosinophilia. So, for example, a patient can come in with symptoms of maybe some dysphagia, chest pain. We would first start with a high dose of the proton pump inhibitor to rule out acid reflux. And then if still symptomatic after this trial, then we would recommend an endoscopy. But our current guidelines has shown, so evidence suggests that proton pump inhibitors are actually better classified as a treatment for esophageal eosinophilia than a diagnostic criteria. So if a patient comes in with trouble swallowing, chest pain, we would start with an endoscopy and then go forward. Are proton pump inhibitors safe? So yes, proton pump inhibitors are well tolerated, and benefits of proton pump inhibitors treatment outweigh potential risk when PPIs are used and prescribed for an appropriate indication by your doctor. What biologics can be used to treat EoE? So we just recently, the FDA approved the first treatment for eosinophilic esophagitis. And it's the first and only FDA treatment that treats the underlying cause of EoE, and that is called dupilumab or Dupixent. So how does dupilumab or Dupixent work? So it targets the underlying source of the inflammation, which is the cause of EoE. So it targets these specific proteins that can contribute to the disease and disease process. Who can get dupilumab or Dupixent for their EoE? So patients have been diagnosed with eosinophilic esophagitis. They must be 12 plus years in age and weigh at least 88 pounds or 40 kilograms. How often do your child or do you have to take dupilumab or Dupixent? So the dose for eosinophilic esophagitis is 300 milligrams injected subcutaneously once a week. And if you can see the slide on the right, the subcutaneous tissue just falls right beneath the skin. And then we inject it, or you or parent would inject the medication either in the thighs, upper thighs. It can be done in the abdomen, at least 1 inch away from the belly button, or the back of the arms. Commonly, what happens is the prescriber, the provider will recommend Dupixent, will send that prescription to a specialty pharmacy. It may come back needing a prior authorization or appeal from your insurance. And once that's obtained and approved, they will deliver the medication to your home. At that time, we make an appointment, a nurse visit, so that the nurse can demonstrate and teach the family member and the patient how to administer the medication. And then the parent or the patient will administer the medication at that visit. The subsequent medication doses that are every other week can be done at home. Dupilumab or Dupixent can come in a pre-filled pen or a pre-filled syringe. So, what are the side effects of dupilumab? So, the most common side effects include injection site reaction. And in the 7 or 8 that we've done most recently, this is probably the most common side effect that we've witnessed is some redness or swelling. There may be a little bit of a hive at the injection site, and that slowly goes away. The Dupixent website also notes that you can have upper respiratory tract infections, cold sores in your mouth or on your lips, joint pain, or eye irritation. So now we're going to talk about dietary elimination in treatment of EoE. So we can use an elemental diet, we can use a testing directed diet, or an empiric elimination diet. And I'll go into detail with these in my further slides. So, an elemental diet is when all food is taken out of the diet, the child's diet, and an allergy free formula is used. This has been found to be 90.8% effective. We can also do an elimination diet. So, we can start with a one food elimination diet, which means an elimination of milk, which would be all types: butter, margarine spread, yogurt, cream, and ice cream. A two food elimination diet is avoiding or taking out milk and all milk products, wheat, and wheat containing foods. A four food elimination diet will include taking out milk and all milk products, egg and egg containing foods, wheat and wheat containing foods, soy and soy containing foods. Or we can do a six food elimination diet, also known as an eight food, and we would eliminate milk, egg, wheat, soy, fish and shellfish, peanuts, and tree nuts. And that's found to be about 72% effective. And then there's a testing directed diet where allergy testing to a child's allergens can be done. Overall effectiveness is about 45.5%, but selected studies in children around 65%. And then only 2 studies in adults with 26.6% and 35% effective. I just included this slide for your knowledge, as it'll be posted later, just on how the dietary approach is broken down, the achievement of making the eosinophilic esophagitis get into remission and decreased inflammation, and then the quality of evidence. I'd like to go over pros and cons of each elimination diet. So the elemental diet, remember, is the diet that we remove all the foods and we're using a specific formula. So it's highly effective, and it is useful in patients with pre-existing multiple food eliminations. But the cons is it may require tube feedings, like a gastrostomy 2 or NG2, may contribute to sensory and oral motor delays in young children, may be difficult to adhere to in adults. It does carry a risk of social isolation. It can be costly for some patients and may require numerous endoscopies to identify food triggers. The test-directed elimination diet, and that's when we're doing allergy testing to determine what foods to remove, it allows more foods to be consumed than an elemental diet. But this cons of this treatment requires extensive testing, most not yet standardized or validated, and it has a higher likelihood of creating setup for acute allergic reactions to food. And then with the empiric elimination diet, this is our 1 food, 2 food, 4 food, and 6 food elimination diets. It allows more foods to be consumed than an elemental diet. It does not require any testing, as we can start the child on these diets after their visit. And for some patients can be less costly than the elemental diet. The cons for this is it requires extensive testing, most not yet standardized. I'm sorry, I apologize. Some empiric diets are quite restrictive. I apologize. And multiple endoscopies may be needed to identify food triggers, meaning if we're on a 6 food elimination diet, the endoscopy comes back clean and we want to add foods. If we would add a food, then we'll need to wait 6 to 8 weeks prior to doing another endoscopy to check if the patient tolerated that food addition. So, what is the role of the allergist in treatments of EoE? As I had described our program earlier in the talk, we have the gastroenterologist, allergists, feeding specialists, dietitians, psychologists, and researchers. So I just wanted to kind of touch on the roles of those right now. So the role of the allergist in treatment of EoE, management of other atopic conditions like asthma or eczema. They can fine tune dietary therapy. They can assess seasonal allergies and role as it plays with EoE. And they can aid in the decision for timing of the next endoscopy. And then also helpful with reintroduction of foods. The role of the dietitian in EoE. So registered dietitians are food and nutrition experts. The dietitian plays a significant role with the management of your child's diet intake and nutritional needs. They will assess if any adjustments need to be made with regards to diet and or supplements. And again, they are experts in food and nutrition. And again, they play an essential role in food elimination diets. What is the role of feeding specialist in eosinophilic esophagitis? So they're skilled at working with children with specific feeding behaviors. They help lower stress and fear about eating. They create steps to successful eating. They set goals to help improve meal times, and they assist with pill swallowing. So a lot of our patients that have EoE may have trouble swallowing pills or have an anxiety with swallowing pills. And then what is the role of the psychologist? So the psychologist helps assess if there are any psychosocial stressors that are associated with the diagnosis of eosinophilic disease. So childhood chronic illnesses such as EoE can often give rise to a host of challenges for families. Um, the psychologist can help manage anxiety, help with communication with caretakers, help managing symptoms and medication compliance, school issues, and they can also help with pill swallowing. And they provide developmental screening to help families understand the impact of chronic illnesses on child development. So, does EoE go away? No, EoE is a chronic condition and lifelong condition. Again, the goals with treatment is that the quality of life will improve as your child or your eosinophilic esophagitis is managed. And again, our goal is to look at remission or get the child into remission. Is EoE hereditary? So it can run in families, but the risk for additional family members is less than 5% unless they are identical twins with the EoE patient. The epidemiology, which how often does this occur? So it occurs 1 in 4 in 10,000. 75% of patients are male. 75% of patients have associated atopic diseases, what we had mentioned before, like asthma or eczema. It's the most common cause for food impaction, and it's actually seen in 12 to 23% of patients undergoing endoscopy for difficulty swallowing. What happens if my child does not take his medications? Well, they can get increased inflammation in the esophagus, increase in symptoms, trouble swallowing, dysphagia, and increased risk of food impaction. And I do want to mention that sometimes symptoms don't always correlate with how the endoscopy or biopsy, what that may show. So it's really important that your child or you take your medications consistently, because symptoms don't necessarily tell us how your disease progression is going. What are symptoms of food impaction? So foods feel like it is stuck and has not passed, not able to swallow other things. They can't drink liquids, they can't swallow any other foods. Your child may actually not be able to swallow saliva. This is an emergency. So if your child feels like something stuck in their throat or esophagus, the swallowing tube, and they're not able to swallow liquids or foods, you will need to take your child to the emergency room. When it's not an emergency, is if they have been able to drink liquids or eat a meal, then that would mean the food impaction has passed. Some people still feel pain or sensation there, but if they have been able to drink liquids or eat other foods, it is unlikely an impaction. Some things to try if you're still having that feeling that foods are getting held up is very cold water, blended ice water. You can use carbonated liquids, Coke, carbonated water, other sodas, or warm to very warm water. So, how often does my child have to do an endoscopy? Well, the endoscopy is provider recommended, and it typically is used to assess for remission after each major intervention. So, if there's been an addition of food, a change in the topical steroid dose, or a change in what topical steroid the child is taking. If the child is having or person is having an increase of symptoms, or and feeding dysfunction can persist and require feeding therapy even with remission based on endoscopy. So, I wanted to say with breaking barriers to care. So, extraordinary minds with strong passion for improving the lives of children have led to these great developments. And it is such an honor to be able to work with several of these extraordinary minds. What is EndoFlip? So, research started on EndoFlip at Children's Hospital Colorado in 2014. We're researching the use of EndoFlip for EoE to see if this will be useful in detecting narrowing and stricture of the esophagus. It can be done with an upper endoscopy procedure. A catheter is gently passed through the mouth down into the esophagus. A flexible balloon is attached to the narrow catheter, and the balloon is filled with saline. And this measures the pressure in the esophagus and the diameter in real time. This can be done on patients with EoE or that have symptoms prior to their diagnosis. And we currently are still doing research, and then also it can be clinically recommended. The barium pill esophagram. So, esophagram, this is a radiology study, and it has been used to evaluate for esophageal stricture and long segment narrowing in EoE and other esophageal disorders. Identifying patients that may benefit from esophageal dilation can be a little challenging if they have a subtle narrowing. Commonly with an esophagram, they've used the liquid contrast, and then they take pictures as that contrast moves down the swallowing tube. Just using the contrast sometimes can miss those very subtle narrowing in the esophagus. So, addition of a barium pill esophagram has allowed detection of the narrowing that may have been missed with esophagram done alone. So, these are pictures of the barium pill esophagram. As you can see on C, you can see that that pill has been held up, or the barium tablet. And I wanted to let you know the barium tablet does dissolve. So your child, or if yourself are having the esophagram and you feel that that barium pill has kind of gotten held up, it will dissolve and pass. And then the transnasal endoscopy. So this was developed from a multidisciplinary collaboration, working together with pulmonology, ENT, and the aerodigestive program. It led to a development of the unsedated transnasal endoscopy. So the child is awake during this endoscopy. This has been going on since 2014. at Children's Hospital, Colorado. So transnasal endoscopy is unsedated. The child remains awake. The provider uses a soft bendable tube. The tube is put into the nostril and gently passed down into the esophagus and stomach. The tube is also used to look in the esophagus. So there's a light at the end of the catheter to visually look at what the feeding tube or the esophagus looks like. And during the test, the doctor will take biopsies of the tissue from inside the esophagus and the stomach. So during the transnasal endoscopy, we have them arrive 15 minutes prior to the procedure. They should not have anything to eat or drink 2 hours before. When we first started the transnasal endoscopy, the average time was 70 minutes from check-in to check-out. Now it takes 40 minutes, and the actual procedure takes about 3 to 8 minutes. And the child can also choose a movie and watch them on the virtual virtual goggles. And then our next very large, huge accomplishment is what is the esophageal string test. So the first string test was done at Children's Hospital, Colorado in August of 2022. This has been a lot of unbelievable work and research for years prior to this coming into fruition. So the esophageal string test is used to evaluate the esophagus for eosinophilic inflammation consistent with active EoE. It's safe and minimally invasive. The string stays in the esophagus for 1 hour. It's done in the office, and it can help with management of EoE without doing a more invasive endoscopy. I wanted to let you know it is in capsule form, so the child will come into the office. They would swallow the pill, and then the end of the string will be taped to the cheek. The pill actually takes the string down the esophagus, and then we'll just wait for an hour. The pill will break away and dissolve, and then the string is actually pulled out of the mouth. Who can have an esophageal string test done? So you must be able to swallow a pill or a capsule. And like I had mentioned before, a lot of our children have trouble with swallowing pills and capsules, but we have working with the feeding specialist, working with the psychologist can help the patient be able to swallow pills. And you can work with your center and your EoE team to learn how to swallow pills and capsules. You cannot have an allergy to beef because the capsule is made of bovine or beef, and cannot have an esophageal stricture or narrowing. So in summary, the clinical presentation of EoE can vary amongst different age groups and children. Treatment is guided by families' goals and priorities, proton pump inhibitors versus topical steroids versus diet elimination, and there are new medications on the horizon. Working together to improve children's quality of life with continued development of new treatment and methods for disease monitoring. So thank you so much. And if anybody has any questions.
Thank you so much, Stephanie. It was such a wealth of wonderful information. We do have some great questions that are coming in. So the first one that came in was about swallowing steroids. So if you accidentally drink something after swallowing steroids to coat the esophagus, instead of waiting the full 30 minutes, should the dose be repeated?
So I would recommend, and you may want to follow up with your doctor regarding that, but if it's been, say, 15 or 20 minutes, I would not repeat the dose. If they drank I actually would not repeat the dose. I would go ahead and give the next dose in the evening. But you would want to check, I mean, that's based on my knowledge right now, but I would want you to check with your physician as far as if you should repeat it or wait till the evening dose.
Okay. If someone's only taking it once a day, is there a certain time of day that's best to take it?
I think there's some controversy with that, but so I think probably evening dose would be the best. You take it before bed, it has time to work, but we have a lot of patients that are also taking it just in the morning. So I think that question is determined on child's schedule, what works out best for family, because we certainly want them to take it. So if evening time is very hard for them, then we would want them to take it in the morning.
Okay. Is there anything they can should else they should consider after taking it, such as do they have to stay vertical for a certain period of time, or they take it and immediately lay down to go to bed?
They can take it and immediately lay down. Just the big thing is no eating or drinking or rinsing mouth out for 30 minutes.
Okay. You talked some about adrenal insufficiency as a side effect from steroids. What labs might be taken to be able to monitor for this side effect, and how often should those be done if it's suspected?
So again, this might be dependent on your center, but currently we would check an AM. It's called an AM cortisol. So what's entailed with that lab draw is the patient would skip their evening dose of steroid and skip their morning dose of steroid. They shouldn't have anything to eat or drink 4 hours prior to the lab draw in the morning, and it needs to be done between 7 and 9 a.m. Now, with the frequency, I would say 6 months. And again, this is provider dependent on what they recommend to recheck that. If the swallowed or the AM cortisol comes back low, we typically repeat that to make sure that we have if we have another low dose, or it may have just been a lab inconsistency. So we will, if it's a low AM cortisol, we'll go ahead and repeat it. If it were to remain low, then you would check with your doctor. But on our end, we would normally see if we can make an appointment with the endocrinologist.
That's really helpful. You talked also a bit about the different options people have for mixing a medication into a slurry, and the variety of different things that it can be mixed with. Have you found that than another, but or is it kind of try multiple and see what works for your child?
So again, your physician may have another recommendation with their center, but what we typically do on instruction is we'll do instruction in the office, and I'd like to do it with the Neocate Nutra, or you could do it with the Splenda, 5 packets of Splenda, and you could actually do 2 milliliters of water just to practice and put the 5 packets of Splenda in, mix that up,
Mm,
and that is the consistency we're looking for. So it's hard sometimes to describe. So we want kind of a thicker consistency, almost like
mhm.
applesauce, to kind of slowly go down and coat the esophagus. But I think what I tell patients and families when they want to know the exact consistency is I'll say you can practice using, 5 packets of Splenda with 2 milliliters of water, mix it, and that's the consistency we're looking for. And then we would recommend you could use applesauce or honey or Neocate Nutra to get that consistency.
Okay. Do they have to use individual packets of Splenda, or could it be measured out in like teaspoon form or something?
So I don't. We say 5 packets, and I
Okay,
don't know how much is in each Splenda packet. So
got
we
it.
usually do packets.
Understood. Um, we've got another question about drinking and swallowing things. So, do you have any tips for children to try and drink their elemental formula if they don't care for the taste of it?
Mm. So elemental formulas now, and they come in. We run into this a lot. So they come in different flavors also, and it may be that working with the dietitian or the feeding specialist, is there another formula that meets your child's need that we can try also, and they may like that taste better. So it's offered in several different flavors, but also different elemental formulas. And I wouldn't want the family to change this on their own. It should be, in addition to your medical team, but different elemental formulas might provide your child with the needs that they are needing nutritionally, but maybe in a better flavor that your child may like.
Do they have to always be drank straight, or can they be mixed with other things to help them be able to drink it?
If so, this very dependent on the child and their health history. If we're strictly doing an elemental diet, no, we wouldn't want to mix anything in there. But some children are on elemental formulas or different formulas to kind of boost their caloric need. So as long as they're not allergic to something you're added, adding in there, that's okay if swallowed. Now, if it's being given via G tube, you have to be careful, just because of the thickness, and we don't want to clog the tube. But again, those decisions would be made with the medical team.
Absolutely. Well, it sounds like there are some creative options, just very much so depending on how and why you're needing to take that formula.
Yes.
Absolutely. Can you share any information about Dupixent being approved for EoE and the experience you're seeing with that with your patients?
Yeah, I would love to. So this has we've probably done 8 injections, or started 8 patients. We've started more than 8 patients on Dupixent or dupilumab, but currently 8 have come into the office and been instructed how to do those injections. And overall, I've had a very positive experience. So some of the things that I'm hearing from families or patients, that when the injection is going in, they can feel the medication, as it is a little bit thicker than your typical like flu immunization. So it's a little bit
Mhm.
thicker. I've also heard from families that if the medication pre-filled syringe or the pen is room temperature, and so we'll often recommend that they leave it out the night before the injection, so it's room temperature. Um, and I've heard some patients have preferred the pre-filled syringe over the pen, but I'm finding that that is more in that population that had done the research study. And so that's how the medication was provided. So they felt more comfortable with that.
That's helpful. We also have a question about singular. How is singular used in relation to EoE?
So I am certainly not an allergist or an allergy nurse. Singular may be used just from the allergy component, as far as the child's, allergy symptoms, as far as seasonal allergies and that. So being given for that. But I would defer that question to one of our allergy experts. And what I can do is have that answer then posted on APFED website. So I'm happy to see if there's any more additional information on that question, and I can provide that to you.
We'd be happy to post that. Thank you so much for following up with your care team.
But that was a great question.
Good. Follow-up question about Dupixent before we jump to a new topic as well. I've got a question here. If you choose to use Dupixent, do you still have to eliminate foods from your diet?
So again, this is going to be based on your center and your MD team. So it's going to be, once you start Dupixent, there'll be a time frame that they'll want the patient to continue either their dial elimination, so that Dupixent has time to get in their system and work. Also, again, with swallowed steroids or PPIs. So I think it might be different based on the center and the MD's recommendation on how long they want you to continue the elimination before they start adding foods. And that is also determined with the allergist too.
Okay. So you have the pleasure of working with children and seeing them grow. As you see them grow, we've got a parent asking a question about how can they find a new care team for their 24-year-old. They've aged out of the children's hospital. They no longer live in the same city as the parent, and they're having a difficulty finding a specialist. Do you have any recommendations for how to locate a doctor and transition from a children's hospital to adult care?
Sure. I would start with asking, what commonly happens with us is with our transition program, we would ask the provider. So I would go to our gastroenterologist, our allergist, and wherever the patient is located, ask if they have a colleague that they would recommend that treats the specific eosinophilic esophagitis. You can also go to the APFED website, which lists a lot of physicians, and we use that a lot actually, that lists physicians that list that as their specialty. Once you find that provider, then you can work with your current MD team and everything to send over records. And you may even ask that they write a letter or something, kind of going over the course of your child's disease process and treatment. But yeah, so you can go to the APFED website to refer to that, and or you can also ask your MD team that you currently are working with if they have a recommendation on a physician.
Absolutely. And if you're heading over to APFED's website to check it out. That's apfed.org. APFED.org. And the tool is called our Specialist Finder. You can be able to search based on location, based on specialty, and be able to learn more about different people all around the country, and even some people beyond the US that are treating EoE and other eosinophilic conditions.
And if there's a nurse coordinator too, they can help kind of manage and maneuver those tedious um, steps, because sometimes it's very overwhelming because you've been with the care team for so long. So if there's a nurse coordinator, there would certainly, I'm sure, be very helpful in helping with some of those steps.
Okay. You talked a little bit earlier about T&E and that new form of being able to do testing. Got a question here. Is a topical anesthetic used in the nose and throat when a T&E procedure is done?
So they may do a couple sprays of lidocaine in the nose and the nair. So if your child, we sometimes will, to make sure that they're prepared or can do a transnasal, we'll say, how do they do with nasal sprays? So they will put a couple sprays of lidocaine up into the nair.
Okay, gotcha. Let's see. You talked before about the challenges of children getting food stuck. What can you do to help your child when food gets stuck? If it's not to the point of needing the emergency room, is there things that you can do at home?
Yes, yes. So we have and I can share this to your AppFed website too. There's a great compensatory measures or strategies that we can use. So wetter preparations of food, so foods that are cooked like in crock pot, um, really harder, like grilled chicken or whatever, might be harder to go down. We want to make sure you cut your pieces of food into very small pieces and make sure you chew them very, very well. If the food is actually feels like it's stuck, carbonated beverages, like we had talked before, colder water, ice water, sometimes warm liquids will help that go down.
Got another question here from someone who is a little more senior in life. They shared that they're 74 and their 50-year-old daughter recently got diagnosed with EoE, and then they just found out that they have it themselves after going through a procedure for something unrelated. But now it's causing them to ask some questions. What kind of conditions can coincide with EoE? Are there known comorbidities that people should be aware of?
So I think, and that's why we have our, and I can find out, I can again ask our experts in this to maybe give a more detailed explanation, and we can post that on the AppFed website. But yes, some of our kiddos that, and I'm speaking children, and I apologize to the person who asked the question. So my knowledge is with children, but we commonly will see other atopic diseases. So like eczema, we'll commonly see asthma, um we can see so those sorts of things. um
That's helpful. Thank you. Circle back to some of the conversation we had earlier about taking medications and drinking and so forth afterwards. So an individual who is using Flovent right now is brushing their teeth right after to try and prevent thrush. But based on some of the comments you shared today, they're wondering if they're not supposed to rinse their mouth and brush right after using Flovent. Can you give some more details about that?
yes, when using Flovent for EoE, we would recommend not brushing after. I know when if a patient has been using an inhaler for like asthma, inhaled, it's common instruction that they brush their teeth after, but we're recommending no, do not brush your teeth or rinse your mouth out. Truly, it's very rare that we see the side effect of thrush, so I would recommend no.
Okay. Another individual has a 3-year-old and they're trying to help them learn how to chew a lot to be able to make things easier to swallow. Do you have any tips on how to get, as she calls it, teaching her little man to chew it real good?
So again, I will defer this to our feeding specialist, and she may want to see if there's a feeding specialist in her and her child's team that can help with that. They would be the expert, and I could certainly, again, happy to take note of the question and see what resources we can provide.
That's really helpful. Well, this has been so wonderful. You have answered so many wonderful questions and given us such great information. Is there anything you haven't had an opportunity to share today that you wanted to make sure to do so?
No, I just really appreciate everybody being here today. And this has been such a great opportunity for me. And I'm very honored that you've asked me to be here today. And I hope I've answered everybody's questions. And if not, certainly you can post other questions and I can make sure that we can get answers for you.
Absolutely. Well, we certainly reiterate that if people have questions, please let us know so that we can be able to help with all of that. Well,
Thank
thank you,
you.
Stephanie, for an absolutely wonderful presentation and for your thoughtful answers to the questions that we received today. I also want to take a moment to thank our education partners for their support of this webinar series. That includes Abbott, AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, and Regeneron. We also hope you will stay tuned for more webinars that we're planning to hold in the future, including our next one on October 18th, featuring Dr. Snyder. She's going to talk to us about esophageal dilation. Specifically, she's going to go into the pros and cons of when to use it. So take a look at apfed.org/webinars to be able to register for that webinar. Another great opportunity to continue learning about eosinophilic disorders is our annual patient education conference, EOS Connection 2022. While the live events happened earlier this summer in July, we have all the great content available on demand, and all APFED's members can be able to access it for free through the end of the year. So make sure to check it out. You can go to apfed.org/conferences to be able to either access it if you're already registered or to be able to register. Another great opportunity to continue learning is through our podcast. You can subscribe anywhere you listen to podcasts to Real Talk Eosinophilic Diseases. In the latest episode just released yesterday, our co-hosts Ryan and Holly had a wonderful discussion about longitudinal research with Dr. Kara Kleber. So if you don't already subscribe to podcasts different places, you can also check it out at apfed.org/podcast. Finally, to continue the conversation that's been started today, we encourage you to join our online community on the Inspire Network. It's a great place to be able to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again, Stephanie, for joining us. And thank you to everyone who participated and submitted questions. We had such a wonderful discussion and questions today. If you have a question that didn't get answered today, please email mail@apfed.org and we'll do our best to get an answer for you. I hope everyone has a great day.